Right. Okay. So, like, you see there. This is a possibility here. We can't see. Yeah, we can't see it. So, yeah.
All right. Any questions from yesterday? Everybody doing fine on your blood flow practices? Making a little bit more sense on how it's supposed to work? Okay. So again, what we covered yesterday was using that big water main outside the house to bring water into the house so that you can do everything you need to in the house. That's our blood pressure. Blood pressure is what makes blood go round and round. If you don't have a blood pressure, blood doesn't go round and round very well. If it's too low, it doesn't go round and round at all. Today what we're going to talk about is how we regulate what goes to the tissue. So in other words, how do I turn on my dishwasher? How do I turn on the shower? How do I turn on the washing machine? Okay, because again, they're not on all the time. Your blood pressure is on all the time. So we're going to talk about blood flow going to the tissues. Now there's a term that we're going to be talking about today called velocity. Velocity is different than flow. Okay. An analogy would be as I was to close the door and we looked out the window and another class was being let out. Flow would be the amount of students passing by the door in a certain period of time. Right? That's the definition of flow. Velocity is how fast do those students pass by them. Okay? And I'm going to give you the example from a blood flow process that would hopefully drive that area down. So what we notice about velocity is that velocity is going to go down as our cross-sectional area goes up. Okay? So let's look at this diagram here to kind of make this point. If you look at the very top, we're going to see what would more than likely be an arterial right here. And this is our capillary bed, the vascular bed, and then that's the post-capillary bed. And if you look at the middle graph, what we have is our cross-sectional area. And then we look at the velocity of blood flow. So even though this is much larger in diameter than these, notice how the cross-sectional area is still very small. Why? Because as we start to move into the capillaries, there are far more of them. The cross-sectional area, in other words, there's more places for the blood to go. This would be the equivalent of if you were able to design the perfect lake that had a river that came into it and a river that came out of it. And the exact same amount that came in per minute had to be the exact same amount that came out per minute. So if I was to look at how fast the water was running coming in, it would go very, very quickly. But as soon as it got to the lake, it would drop down dramatically. The flow's the same. How do I know that? Because I'm pushing in the same amount of fluid, water, in the lake as what's draining from the lake. But if I was to look at the velocity of the river and then look at the velocity of the lake is going to become, it almost looks like it's not moving. Okay? The velocity goes down. So cross-sectional area goes up here. So this would be the river, this would be the river, this would be the lake. Why is velocity going down? A lot more places for the blood to go. So it moves slower. The flow is exactly the same. Okay? Now, what do you imagine is the purpose of this velocity decreasing down dramatically there? What's the point of it? I can hand the peanuts out better. It's my exchange vessel. Hey, this is your job. Your job is to hand the peanuts out. I'm giving oxygen, I'm giving glucose to the tissues. Now I have time to do it. Why? Because the velocity decreases dramatically. Okay? So it is definitely beneficial from that standpoint. Now, when we talk about the regulation, so a question came up yesterday is, are these capillary beds always closed, always open? When are they closed? When are they open? They're open based off of two tell you that in your book, you've got this diagram here, which talks about extrinsic and intrinsic. Okay? Now these are some words that you need to start putting into your head because they come back in a lot of different systems. Intrinsic means in-house. In other words, everything's right there. Extrinsic comes from some other place. We talked about this in hematology. There was an intrinsic pathway and an extrinsic pathway. The extrinsic pathway needed something outside of the blood to start the process. Okay? So when we look at what regulates blood flow to the tissues, we have an extrinsic system, which is basically our nervous system, our sympathetic nervous system, to be specific, and our hormones. And then some extra chemicals that wouldn't be classified as hormones. But basically things that are coming from outside. Some of these we went over the other day. We had our nitric oxide. We had our angiotensin II. We had our atrial natriuretic peptide. Things that come from outside of the area of the blood vessel itself. And then intrinsic are all things that basically have to do with metabolic in the muscles. Okay? So we're going to kind of tackle those here just to put everything in perspective. So the first one's metabolic. So, and it's autoregulation. And I want to make sure I cover autoregulation because, again, we're going to spend a lot of time with it in AP3 with the renal system. Autoregulation essentially means as long as I operate within a certain set of rules, I can do whatever I want. I don't care what's happening in the rest of the body. I'm just here in my own little community and I'm just sitting here regulating the trash coming in, I'm regulating the yard work, I'm doing everything all on my own. Okay? That's what autoregulation is. So it's a local process. That's why this is considered the intrinsic system. Okay? Extrinsic is mom and dad. Intrinsic are the teenagers. So let's say that mom and dad left for the weekend and the teenagers got to stay home, and they're going to be able to stay home as long as they operate the rules that mom and dad set. Okay? So we're going to just change that up slightly because they're not going to operate the rules. That's the analogy I want to use. So if I'm by myself, I'm going to have a party. Okay? So what do we generally have at parties? We have something to eat, something to drink. So I'm probably going to have some delivery people coming to the house, delivering what I want, what I need. Okay? Pizza and beer. That's what's coming to the house. Well, at the end of the weekend, or as the weekend progresses, what did the pizza come in? What did the beer come in? Bottles and cans. So once they're empty, they now have wastes. So we got to pick up the waste. So what's generally happening is as your tissue cells are requiring things they need, it's going to increase the amount of blood flow to that area. With every metabolic process, there's always waste. The pizza boxes and the beer bottles. And please don't take away that that's the nutrients that you need, is the pizza and the beer bottle. So I got to pick those up. So it's not only the needs, the nutritional needs of the cells, but also the waste that's being produced. So those are the things that will increase blood flow to tissues. Okay? So when we look at some of these things, we've got increased CO2. Okay? So if I'm making ATP, the side product of ATP is water and carbon dioxide. I want the ATP. I can use the water. And remember, carbon dioxide produces that. And the more that I have, decreases my pH. So CO2 is a waste. I don't want it. So whenever we're producing more CO2, that's going to be the body's signal to say, hey, we probably need to send more blood to the area to pick up the CO2 to get rid of it out of the body. Okay? Hydrogen ions are a waste. The increase in potassium is a waste. decrease in oxygen cause an increase in blood flow? And before we do that, I want to make sure everybody's familiar with the picture. The blood vessel on the top, is the diameter bigger or smaller than the blood vessel on the bottom? Bigger. Why? It's going to bring more blood to the area. Okay? How do I vasodilate a blood vessel? How do you make it bigger? What's the mechanism? Not what caused it.
Relaxation.
Relaxation of smooth muscle. Smooth muscle relaxes, vessel diameter gets bigger. What happens to resistance? Goes down. That's the way you should be thinking about this stuff. It's going to help you put everything in its own little picture for your exam. So, why would a decrease in oxygen cause vasodilation?
The area needs more blood flow.
The area needs more blood flow. Hey, I got to have oxygen. Remember, the whole point of making ATP, when I do it without oxygen, I get about 2 to 4 moles of ATP. With oxygen, 32 to 36 moles. So tissues are screaming, hey, need some oxygen over here. Okay, well, let's vasodilate. When I vasodilate, brings more blood to the area. Hopefully more blood is going to bring more oxygen. Okay? Just since we're playing a little review game, what is the term that we use when any part of the body has a decrease in the amount of blood flow? Ischemia. What does it mean when I have a decrease in the amount of oxygen delivery to the tissue? Hypoxia. Now remember, a lot of times they go hand in hand. But I can have a patient who's ischemic and where I have a decrease in blood flow, but if I put them on supplemental oxygen, I'm jacking their oxygen up. I might actually be delivering enough oxygen to that tissue to be useful. Okay? So they do generally go hand in hand, but they do not always have to go hand in hand. So does everybody understand the metabolic component? It's the nutritional needs of the tissue as well as an increased amount of waste. Those are the two things that will increase blood flow to an area. Now, if those things go down, if I'm outside and it's cold and you know don't have your mittens on, then I have tissue that it's not metabolically active. Therefore, I can decrease the amount of blood flow to that area. So that would potentially cause the vasoconstriction. The opposite is true. I don't need as much nutrients. I don't have as much waste being done. Therefore, I don't have to have the same amount of blood going to that area. Now the other one is a little harder for people to understand because they're trying to put this whole little picture in of a big giant circuit, but it's referred to as the myogenic mechanism. The myogenic mechanism, we'll think of the word first. So the prefix of the word myo means what? Muscle. Okay? So myogenic, if I was to have this table, okay, and want to make sure that you think about it the right way. This is a big giant tube, okay? And water comes in on this side. And grandma's little tchotchkes are down here, all the things that she's collected on her little table over here, and they're very, very fragile. But they need to be cleaned. So we have water that comes down every now and then, just kind of washes over them, okay? If too much water comes through, what happens to the tchotchkes? They break, okay? So the myogenic response is when a blood vessel is stretched, the response is to contract. The muscles contract, so you have vasoconstriction. Now, I want to make sure everybody's clear on this. The myogenic response is not the ability of the blood vessel to stretch. The myogenic response is what happens to the blood vessel when it is stretched. And you have vasoconstriction. So if I have somebody who's not paying attention and they just jack the water pressure up on this side of the tube, there's going to be pressure sensors here. And they're going to say, oh, that's way too much water coming in. If all that water came in, all this delicate tissue, which is what the tchotchkes are going to break. So what happens is pressure is felt here. And then there is a vasoconstriction. say that somebody just kind of turned barely a trickle of water all over here. And it's not going to be enough to get all the dust off the nooks and crannies of the little tchotchkes. Everybody knows what a tchotchke is, don't they? If you've ever been to Grandma's house, she's got all those little figurines and all these little things that are stuck there that mean something to somebody, her probably, and you never want to be the one who has to dust them and clean them. So if the water is just a trickle, then these aren't going to get clean. So what happens? Because these aren't being stretched, they will then vasodilate. And when they vasodilate, more water comes through. Okay, and I want to make sure everybody's clear on the analogy here. Okay, this is a blood vessel. What I call the little tube that cleans Grandma's tchotchkes. The water over here is actually blood. The tchotchkes are our delicate tissue in the capillary bed. Okay, I'll give you an example of how this occurs or what happens here. Every month in the female reproductive cycle, they have two of them. You have an ovarian cycle and you have a uterine cycle, which most people call the menstrual cycle. There is going to be a certain amount of blood. So, first off, they're going to vasoconstrict, and it's going to deplete this tissue of blood. So it gets very, very fragile. And then based off of hormones, suddenly I'm just going to turn this on full bore. And the tissue, the blood comes into this tissue that's been deprived of it, so it's very delicate, and just crushes it. So it sloughs off the uterine lining. So it has this way of basically responding to pressures on the other side. Okay? But I don't want that to happen everywhere. I don't want it to happen in blood vessels that are coming to my skin. It would just trash the skin. So does everybody have a pretty good grasp of the myogenic response? Again, the myogenic response is not the ability of a blood vessel to stretch. It's what happens when the blood vessel is stretched by increased blood. If it's stretched, the myogenic response is vasoconstriction. If it is not stretched enough, it's going to be vasodilation. I'll get your question in a second. The physio suite that I keep talking about has a section in there, and I can't remember if it's a blood vessel, and I'll see if I can find it, because the physio suite might be on here. But it shows a wrestler inside a blood vessel. And the wrestler starts to push against the wall of the blood vessel. And the wall of the blood vessel pushes back down on the wrestler until he relaxes and is not pushing against the wall anymore, and then the blood vessel vasodilates. Okay, this one.
Does myogenic response only happen in the capillaries? Like, is it
No, it doesn't happen in the capillaries at all. It happens in the arterioles. It's to prevent stuff from getting into the capillaries. Because if too much blood comes in, again, remember we talked about capillaries. Capillaries are fragile. They're very, very thin because they're exchange vessels. Too much blood flow, too much pressure has the potential of damaging. Any questions so far on that? Yes, sir.
the pressure in the vessels, is that felt by the baroreceptors?
And just in case you ever do pick up any other textbooks, that's the one, again, frustrating thing about science in general is that there are different terms. So if you pick up a different textbook, you might see the term pressoreceptor. Doesn't sound as good as a baroreceptor, but they are one and the same thing. Endothelins. They're just chemicals that are released from the endothelial cells, and they're not that big. Pardon me? No. No, that is, so when you look at this particular diagram, these are things that cause vasoconstriction on an intrinsic side. In other words, locally, myogenic is stretched, anabolic is endothelial. Yeah, they just cause a vasodilation. But it's a chemical that I don't really care that you know because it's not that big of a deal as opposed to the things that cause the vasodilation, the wastes. Nitric oxide sometimes would be called that. Nitric oxide used to be called the endothelial derived relaxing factor, PDRF, and it kind of fits in this process. So nitric oxide doesn't really belong in this one because it's really not a hormone. It's something that's released from the blood vessels. Now I do want to show you this picture before we move on. I'm going to talk about specific tissues because every tissue for the most part responds to what I just talked about. But some of them have some extra qualities that regulate their blood flow. But here, I do want to show you just kind of how the body is able to continue to deliver tissue. So if I take somebody who's at rest, we have a 5.8 liters per minute for a cardiac output. That's about 5,800 mils per minute. And then I start exercising, so I'm going to go up to 17.5. And your cardiac output can actually go up. You're extremely well trained. You can go up to anywhere from about 25 to 35 liters per minute. Okay? But you can see that for the most part, brain stays the same. I don't change the amount of blood flow that I send to the brain when I'm exercising because the brain has to remain fairly constant. There's no reason to send anything extra up there. Heart obviously goes up because my heart's going to beat faster. It's going to need more oxygen. Skin is a little bit higher, but the big one is right here, skeletal muscle. I'm going to obviously increase the amount of blood that goes to the skeletal muscle because they're going to be more metabolically active as they're moving. Why does the skin go up?
Sweating.
Heat. It's heat regulation. We want to make sure we exit. So remember that muscles are only about 40% efficient. So if I'm putting 100 units in, I'm only using 40 of those units. The 60, we can't create or destroy energy. It has to be given off as something else. That's the heat. That's why you get warm when you do anything. Well, you can't get too warm or else your body's going to shut down. So you start to sweat. We're going to increase the amount of blood that goes here so that we can get rid of the heat from a radiant standpoint. These are all things that are for body control. Notice how my kidneys shut down. We don't necessarily have to pee as much when we're out running, doing exercise, which is a good thing because I might need that fluid, okay, as part of my circulating blood volume. Abdomen, so this is the reason we were talking about swimming after, or going swimming an hour after you eat, which is a myth. But it does decrease when you start exercising. But keep things going to our skeletal muscle. So you're really not going to, people think you're going to cramp up from your muscle standpoint, you're going to cramp. It's the opposite. You're going to get diarrhea because I'm shutting down blood flow there. And then just the other parts of the body start to decrease a little bit. Now, skeleton. So our skeletal muscles, okay? So these are more specific than just the increased oxygen, the increased waste, and so forth. Now, the problem with this is that when we exercise, so make sure you write muscle in there because it's skeletal muscle. We're not talking about the skeleton itself. I'm going to be increasing my sympathetic nervous system. Sympathetic nervous system has those three primary receptors to it, beta 1, beta 2, and alpha 1. Anybody remember what alpha 1s do? Cause vasoconstriction. So how would vasoconstriction be beneficial to my skeletal muscles when I'm trying to exercise? Wouldn't. So the local response, which is the need for oxygen, overrides that sympathetic nervous system there. It doesn't override the whole sympathetic nervous system. It overrides the sympathetic nervous system's impact on skeletal muscle. And it causes a vasodilation. That way, I can have a dramatic increase in the amount of blood. This also, by the way, just a side note, goes to that there's a big myth that if you lose weight and put on more muscle mass, that you're going to burn more calories throughout the day. If you're not using your muscles, you're not really burning calories. Yes, if you put on more muscle mass when you use them, go out and exercise, then that's fine. But if you're just laying there watching TV or sleeping, your muscles are not any more active. So the idea that your basal metabolic rate, the amount of calories that your body uses just as you lay here and breathe, is just patently false. There's no science that proves that. Next one is the brain. The brain primarily utilizes oxygen as its need for blood flow. But it also responds with our pH. Okay? So I've talked about this a couple different times. The last one was when we were covering the central nervous system, which seems like a long, long time ago. This is my skull. My brain fits in here. And obviously we have brain stem and then spinal cord. Remember that the skull doesn't grow. So if I have a decrease in my pH, which is caused by an increase in my hydrogen ion, that's going to cause more blood to come to the brain. Now, I can utilize this physiology by treating somebody who has a head injury. Because if they have a head injury, their brain is going to begin to swell. One of the ways that it swells is we're bringing more blood to it, and then fluid leaks out of the blood vessel into the tissues, and that's what causes it to swell. So I can probably decrease the amount of blood that goes to the brain. And I can do that knowing that big long equation that I told you. I'm going to shorten it up here. That big long equation with CO2 plus water gives us carbonic acid breakdown to bicarbonate hydrogen ion. It's just short, so we'll just write, left things out. So whenever I have an increase in CO2, I'm going to have an increase in hydrogen ions. So one way I can treat this patient is I can decrease the carbon dioxide in the patient's blood. So when I'm treating a patient like this, if it's emergent and we haven't put a big giant monitor that goes down into their ventricle, it tells me what their intracranial pressure is, I can check by seeing if my cranial nerves are being activated or being destroyed. So we look at our pupils. Okay? But if I see this elevated and I drop this down, then I decrease the amount of swelling that the brain has. So whenever this brain swells and starts to push that brainstem out, remember, 10 of the 12 cranial nerves came from the brainstem. So if I'm looking to see if my patient has pupillary response, and they don't, then there could be a problem in the brain. So we can do this, and I will tell you that I can lower this down in about 20 seconds. And I can change this, the ICP, which is an indication of the amount of swelling, down in 20 seconds. But you have to have a tube in the person's throat, because that's how you're going to be able to control their carbon dioxide. Okay. Skin, predominantly temperature is the big driver of skin blood flow. Oxygen to a much smaller degree, but those are the two main things that drive that particular blood flow. Heart, oxygen and myogenic. Myogenic is very important because of the tiny, tiny coronary vessels that serve the heart itself. So it responds to myogenic more than some of the other tissues. Now, out of all of these, the lungs are the most bizarre, okay? Because they work opposite of everything else. Remember, if my tissues need oxygen, what do the blood vessels do? They dilate. I need to bring more blood to the area. Okay? In the pulmonary system, it's just the opposite. And it makes sense. So you'll get used to this. This is basically the general description of the pulmonary system. Okay? this is that blood's going to come to the area, pick up oxygen, and get rid of carbon dioxide. So if this air sac, this alveolus, is not being ventilated very well, remember the whole point is that red blood cell needs oxygen so it can take it to the tissue so that we can make more ATP, get more ATP, our bang for our buck. So if for some reason this decreases or shuts off completely, as blood is coming through here, it's like, well, there isn't any oxygen here. I'm supposed to pick up oxygen. I know the routine. And it eventually will just vasoconstrict. And we won't send blood to that alveolus because it's not doing its job. Give you kind of a non-physiologic analogy. Let's say you and your buddy want to start exercising. How about we get up in the morning at 5:30 and go running? I'll come by your house at 5:30 and pick you up. Okay. First day you come by, just go ahead. I'm not getting out of bed. So how many times do you think you're going to stop by that house every morning before you just stop going to that house every morning? He's not getting out of bed, so we might as well just go run by ourselves. Same thing is true here. What's the purpose? Take up oxygen. No oxygen, not coming by anymore. Okay? This is called hypoxic pulmonary vasoconstriction. Now, we also learned that a increase in our hydrogen ions, so a low pH, causes vasodilation in most tissues, correct? Why? Because it's a waste. I need to get rid of it. Okay? In the pulmonary system, if I have an elevated hydrogen ion concentration, and again, this is one of the reasons why I wanted to make sure that you guys know the relationship of pH to the hydrogen ions. Remember, the pH does not designate what happens to hydrogen ions. It's hydrogen ions that designate what happens to pH. pH is a reflection of the activity of the hydrogen ion. It's an inverse relationship. As hydrogen ions go up, pH goes down, and vice versa. So when this area, when the blood flow, where the pH of the blood tends to be low, that causes a vasoconstriction. And then the opposite's true. If I increase my pH, it causes a vasodilation. Now I'll give you an example that, again, using it kind of like I did with the herniation, how you might be able to utilize that knowledge. This is a example. I'm not going to show up on an exam. Just try to drive the point home of how you can take this physiology and apply it to a clinical situation. There are times where, so we know about our blood flow pattern because we've been talking about it. So I have my heart. Artery, pulmonary vein, aorta. What's this chamber here? Right atrium. What's that valve right there? Tricuspid. What's this chamber here? This chamber. What's this valve? Mitral valve. What's the name of the mitral valve? Bicuspid valve. And then this obviously would be the left ventricle. So this goes to the lungs, correct? So when baby is inside mom, we talked about those two special adaptations to the heart. We had the paved foramen ovale here, and we had the ductus arteriosus there. Okay? The reason why is because these lungs are filled with amniotic fluid. blood goes through, it's like, well, I don't really want to go down here. It's a lot of work. I'm going to cut over and go this direction. So when the baby's born, again, especially when it's a vaginal birth, comes down the birth canal, we're squeezing, gets all that fluid out as the kid comes out, fills with air, and now it's much, much less resistance. Okay? However, there are situations where the kid maintains what's called pulmonary hypertension, which means the blood pressure in here is very, very high. So the blood doesn't want to go through there, so the kid stays in this fetal circulation. That patent ductus arteriosus stays open. So if I was to go pick this kid up, and I see that the kid's not oxygenating very well, because they oxygenated fine inside mom with the patent ductus, but when they're outside, it's not going to the lungs, so they're not picking up oxygen. They're not hooked up to mom anymore. Their lungs need to work. So we would look at a chest x-ray and go, well, the lungs look good. So this is not a lung problem. So then what we would do is we'd put a tube in the kid's throat, and we would ventilate them, and we would decrease their CO2. So we're going to take this step by step. If I decrease the CO2, what happens to my hydrogen ion concentration? It goes down. What happens to my pH? It goes up. So suddenly, I've changed the pH, and now blood is going to the lungs. So based off of knowing the physiology, this, as we start to ventilate, bring the carbon dioxide level down, then blood starts to move through here, and the kid starts to oxygen. And then we just need to figure out why the kid has pulmonary hypertension. There's a lot of different reasons for it. Any questions on that? Okay, so those are just some special adaptations, so to speak, how certain tissues will change. Now, this part right here is probably the most confusing to students because of the theory behind it, and so I'm going to try and explain it the best I can. What I'm probably going to do is just take a quick 5-minute break so people can kind of clear their brains, go get some water, because again, we're going to get done early. But just take about 5 minutes because I want to make sure everybody's brain is fresh for this next part of the lecture. Okay? So we have a hydrostatic pressure inside the capillary pushing out, and then I have a hydrostatic pressure in the interstitium pushing fluid back into the blood vessel. Okay? So there's 2 of the pressures out of the 4. The second type of pressure is referred to as an oncotic pressure, or the colloid osmotic pressure. So you oncotic, colloid osmotic, same thing. Now, for the most part, they are, that pressure is derived from proteins. Proteins are water magnets. They pull water towards them. So instead of being a pushing pressure like the hydrostatic pressure, they're a sucking pressure. They pull towards them. Now I have proteins inside my blood vessel, so they're not only going to hold on to the fluid inside the blood vessel, pulling it towards them, but they're going to probably want to pull fluid from the interstitium into the blood vessel. So that's the third of the 4. Now, I could potentially have proteins here in the interstitium that would want to pull, suck fluid towards you, towards them. Possibly suck fluid out of the capillary towards them. That's the 4th pressure. So it's actually pretty straightforward. You have 2 hydrostatics and you have 2 oncotic pressures, 2 colloid osmotic pressures. Just happens to be their location. One's in the capillary, one's in the interstitium. So when you look at this picture, obviously this is the capillary here, this is the arterial end, this is the venous end. These are the tissue cells, and then the blue is my interstitium. So I have fluid here, net hydrostatic pressure. So there's not a whole lot of hydrostatic pressure that's out in the interstitium. Most of it's inside the blood vessel. So when I add up what's pushing out and what would be cutting in, 35 minus 0, so it's 35. Okay? look at the oncotic pressure, the colloid-osmotic pressure, I've got 26, because proteins are inside my blood vessel. Proteins, like our red blood cells, don't really move out of the blood vessels very well, which is a good thing, because what are proteins? Water magnets. If they move out of the blood vessel, guess where the water goes? Out of the blood vessel. If water goes out of the blood vessel, do I have a high stroke volume or a low stroke volume? If I have a low stroke volume, what does that do to my blood pressure? Goes down, which means blood doesn't go round and round. So that doesn't make a whole lot of sense. So I really have 26 pushing out, or pushing in, excuse me, because it's pulling. Remember, this is a sucking motion, and then 1 going out. So you add up the things going out, subtract the things coming in. The one that has the highest number is the direction of fluid movement. So at the arterial end of the capillary, it favors fluid moving out into the interstitium. So we take our nutrients to the tissues. Yes? Which part?
The arterial end.
So at the arterial end, we looked at the things that were going out. We subtracted the things that were pulling in. Whichever one was the largest, that's the direction fluid goes. So here I have 35 pushing out. I've got 25 pulling in. So obviously there's a greater pressure moving out. Okay? Now again, the Physio Suite, I can't remember if they have, I'll get your question in a second. If they have this, this particular analogy I'm going to talk about, they have it in the renal system. So this is called our net filtration pressure. So the example in the renal physiology, to give you an idea, is if I have number 55 on one team, who's huge, and I've got 30 and 15, 2 other players on the opposing side that are much smaller, they're pushing on me, number 55 is pushing on them, and who wins? Number 55, because he's bigger. Okay? So you're just looking at the 2 forces. I've got 1 force pushing fluid out, 1 force pulling fluid in. The bigger the number, that's the direction fluid's going to go. On the arterial side, in other words, at the beginning of the capillary bed, it favors fluid moving into the interstitium. Yes, ma'am.
I was just wondering if I was reading the picture correctly. So the pressure out is a positive number, and then negative number is pressure that goes in. Is that correct?
Yeah. I mean, I wouldn't necessarily think of it that way. I'd be thinking more of an absolute number.
Okay.
To be very honest with you. But I've got 2 pressures here. What isn't being shown here is that in just this arrow, ignore all the other arrows, just this arrow, I've got 35 pushing out, and technically I don't have anything pushing in. What are the 2 ones? These are hydrostatic pressures. This is caused by the fluid inside here pushing out. This, the 0, would be indicative of fluid in the interstitium pushing in. That's what's represented by this. This is just my proteins. I have more proteins inside my capillary, so I have 26. And again, what type of movement is this? This is a sucking pressure. It's wanting to keep the water with it. And potentially it can pull water in from the interstitium. Here I have 1 that would be in the interstitium. So just on this arrow, I've got 26 pulling fluid in, or keeping fluid in, and only 1 having fluid go out. Who wins? The one coming in. Then I add up the difference between my hydrostatic pressures and my oncotic pressures. And that's what dictates the overall fluid moving out. Now, if fluid moves out of the capillary, I don't really have a whole lot of fluid in my capillary anymore, correct? So what happens to my stroke volume? If that happened and did not get rectified? What happens to my blood pressure if my stroke volume goes down? Goes down. So blood doesn't go round and round. So obviously this can't be the end of the story. On the venous side, so as we're starting to approach that post-capillary venule, because we lost fluid, correct? Fluid left on the arterial side. So now when we do these exact same numbers again. We look at our two hydrostatic pressures. One's inside the vessel, one is inside the interstitium. We look at our oncotic pressure. One's inside the interstitium, one's inside the capillary. So here, my net hydrostatic pressure, I lost fluid, did I not? Down here? So my hydrostatic pressure, I have less pushing out now. And this is still zero. Why? The interstitium's a big place. The fluid spreads out. So it's really not concentrating and doing it like it's supposed to. I didn't really lose any proteins because proteins don't leave the blood vessel. So when I add up my oncotic pressure, I've still got 25. So here I've got 17 pushing out, 25 pushing in. Who's going to win? Pushing in. So I reabsorb most of the fluid that went out. And I restore that value. Now, this is from still even an earlier textbook, and I can't remember, I'll have to look in just a second, see if this is one of the most current textbook. But this is basically saying the same thing, except the difference is it's labeled a little bit better. This tells you what hydrostatic pressure is. This tells you what our osmotic pressure or oncotic pressure is. Osmotic pressure, colloid oncotic pressure. Blood osmotic, colloid osmotic is the same as oncotic. Two different words, but they're the same thing. It even tells subs, pulling fluid in. So here I've got my arterial, postcapillary venule, capillary. At this end, I've got more fluid. My hydrostatic pressure is 35, my oncotic pressure is 25. We add those together, and net filtration pressure is 10. Fluid moves out at this end, moves back in at that. Because again, if I did not recover that fluid, you would probably be dead in, probably about 5 minutes. Because as blood starts to go around and around in our cardiac output, you're going to start having all the stuff leak out into the capillaries. You're going to be the Pillsbury Doughboy, and you're not going to have any fluid in your vascular system. So your blood pressure will be low, and if it's not rectified, you'll die. So this is again more of a big picture type of a thing. Not really going to look at this particular one, but blood's coming in, so it's going to cause the fluid to leak out, and then it's going to get reabsorbed on the side. So it doesn't go into the specifics. It does talk about the hydrostatic pressure here. That's that pushing component. Here's the sucking component of the proteins. We'll talk about the green next Wednesday when we get done doing the exam, because the green is our lymphatics. Because this doesn't collect every drop of fluid that leaked out. There's still about 3 liters that the lymphatic picks up every day and returns back to the blood. So I do believe that on the previous one, those two were on that PowerPoint unmoved. So if somebody will remind me, because the old brain doesn't work that well sometimes, is I will try and post it so you have about 3 different examples of it. And I can put in 18 different pictures from 18 different textbooks. But between her, last 3 changes and so forth, she's got 3 different pictures. And they explain it somewhat different. So I will make sure that if someone emails me that at least the diagrams are put on there so that you have those access to your Any questions? Okay, so one last part and then we'll be done, which is shock. We're going to talk about shock. Now, I want to make sure everybody's clear, especially those people who've taken first aid. This is not the shock that you experienced when you were in a car accident. Oh, the patient's not talking to me. They're in shock from the accident. That's a psychological thing. The shock I'm going to talk about is an actual physiological response. Okay? The easiest definition of shock is I am not delivering to the tissues what the tissue needs. Now, depending on the audience and the, so I always will teach that there are 3 types of shock. So when I teach pediatric advanced life support class that's done by the American Heart Association, we teach 4. I'm going to put the 4th one, heart lungs, which is there. So if you ever end up taking another class and shock is hypovolemic shock. So if we think about the term here, hypo meaning low, vol meaning volume, volemic, volume of blood. So the volume of blood has gone down. Okay? Probably one of the more common causes is bleeding. If I cut myself, if I'm involved in a trauma, if I break a bone, blood does not stay in the vascular space, it leaks out. What do you suppose the treatment for it would be? If I don't have volume, what should I probably give the patient?
IV.
Volume through an IV. Yeah, this is not something that we, here, take a little sippy cup and have some water. Losing a liter out of my broken femur. I don't think a sippy cup is going to help. So you'd start an IV and we'd go ahead and give the patient fluid. Okay? I'm not going to ask you on an exam, but the type of fluid we'd probably be giving these people are normal saline. Probably one of the most easily accessible fluids that we have access to. Anybody think of a couple other reasons why you might have hypovolemic shock? What are some of the reasons why you might lose fluid from your body? Fluid from your body. Dehydration. How do I get dehydrated?
I'll drink enough water.
Yeah, but you're probably going to be driven to drink water. So when we get into ANP3, the renal system or thirst mechanism is going to kick in. So unless I'm somewhere out in the desert, which is not a more common thing, because hypovolemic shock again is the most common type of shock. So dehydration, but what causes dehydration? Diarrhea. Vomiting, diarrhea. This is probably the thing that kills more kids throughout the whole entire world. The treatment for it's very easy, IV and fluids, and maybe some antibiotics for whatever the reason is. But third world countries that they do their laundry, they wash their dishes in the same water that the animals go to the bathroom in. So they get dysentery, they develop diarrhea, and they can die from it. Okay? So vomiting, diarrhea, prolonged sweating. Kind of goes along with not being able to drink, but if you have a fever, those are types of things. It has to be some profuse sweating for you to become dehydrated. The next one, it says vascular shock because that's the term that your book uses. I would like you to know the other term for it, and it's referred to as distributive shock. It actually encompasses 3 types of shock. So, we talked about what a blood pressure was, correct? Blood pressure was essentially putting pressure or tension on a particular part of the arterial wall. We like a blood pressure. We like tension. We like pressure. That's how things go, make blood go round and round. So if I have $500 square foot home. Mom and dad, 8 kids. Suppose there's very much privacy in that house? Suppose there's a lot of tension in that house?
Yeah.
Okay, we like tension, remember? Tension's good. This kind of tension might not be good when I'm using it. These guys win the makeover. Okay? So now, do you like my house? So they go into a 10,000 square foot home. I didn't get rid of anybody. Still same. Mom, dad, 8 kids. They each have their own room. Suppose there's any tension in that house? No. We need tension. Tension's our blood pressure. So in distributive shock, in vascular shock, what happens is the blood vessel gets bigger. But I didn't lose any blood. But since it's bigger, is it able to push against the vessel wall? No. This is sometimes referred to as a relative hypovolemia. I didn't lose any fluid. I just made the container bigger. So that fluid that was able to provide a blood pressure is no longer able to provide that blood pressure. What do you suppose the treatment would be for this? Vasoconstriction. How about we move this poor family back into the tiny home? How about if I take my blood vessel and I bring it back down to its original position? So probably for your guys' level of knowledge at this particular point, the big one that would fit in here is a thing called an anaphylactic reaction. People that are allergic to peanuts, people that have bee stings. Okay? This is a classic response. That's the reason why. Anybody know what we give a patient that has an anaphylactic reaction? Their EpiPen. You jab it into their thigh. Epi is a vasoconstrictor. Because those blood vessels, I mean, it does a lot of other things, which is the reason why we use Epi, because it also decreases the swelling, it also decreases the constriction in their bronchioles. But it's a vasoconstrictor. The other two that I don't really, I just want you to know that they're there. One's called a neurogenic shock. This is what happens when we have spinal cord injuries. And the other one is called septic shock. So people that have an infectious process going on. So that's all classified in distributive shock.
So would the vascular distributive be the same as anaphylactic shock?
No. Anaphylactic is an example of distributive or vascular. And the last one is cardiogenic shock. What's the big word that you see here? So what do you suppose the problem with cardiogenic shock? How about, yeah, just the organ, the heart. The heart's not doing its job. It's not pumping correctly. So I can have a heart that's got really big, fat, floppy because it's in failure and it's not able to pump blood in a forward direction. So what do you suppose the treatment for that would be? Surgery would be very, very late or very, very early. You either got to hit it early or it's going to be something that is basically just going to kill you faster. So if my heart's just pumping like that, and you don't have to know the drug or anything, but what might I do for the heart?
Speed it up.
Speed it up, or
Contractile strength.
I can make it do this. So I would give drugs that make it either be faster, if that's the problem, or squeeze harder, so it pumps more blood forward. Now the fourth one that AHA uses that I put in here, you don't have to write this down, but I just want to make the story complete, is a thing called cardiac tamponade. That's that thing I started off the class with, where the blood, the pericardium fills with blood, and it pushes down on the heart. Okay, the heart still has electrical activity, but I can't push any blood out. Okay, that'd be an example of they call it obstructive shock. I put it in cardiogenic shock. A thing called a pulmonary embolism. So if I have this big giant clot in my pulmonary artery, blood can't push out, blood can't get past it because it's so big, then my blood pressure goes down because the heart can't work as hard. And then the one that we'll talk about in ANP3 when we get to the respiratory system works somewhat along the same way as the cardiac tamponade. So remember, the cardiac tamponade, the heart's going to be here and it's going to fill with blood, so I wouldn't be able to have any blood go out. Well, the same thing can happen to the lungs. The lungs can actually have air that leaks into the cavity around it, and then the lungs push down. And when the lung pushes down on the heart can't be breathed. Okay, it's called a pneumothorax. We'll talk a lot about it. So those are not going to show up on the exam. But you should be able to describe what hypovolemic shock is, vascular distributive shock, and cardiogenic shock. I don't need the examples of them. Except for hypovolemic shock, you should be able to tell me the dehydration, hypovolemia, that type of thing. Any questions? All right, so again, Monday we will be doing heart dissection, EKGs. Tuesday's your exam. Wednesday we'll go over them, go over the lymphatics. Thursday we'll start immune. The following week we'll